Hey guys, welcome back to another episode of the Making Strides podcast. So today's a special episode. We have another guest. We have Emily Schwerdt. This is actually Adam, the co-host's wife, and she's also a runner and she's also a physical therapist. So Emily, why don't you introduce yourself?
Hey, I'm Emily, as AJ so eloquently said, and I am a physical therapist who specializes in pelvic floor physical therapy, as well as I just kind of treat orthopedics as well. But my love is pelvic floor therapy and kind of treating the female athlete. So.
Yeah. What is pelvic therapy? Like, what does that really mean? I don't think a lot of people necessarily know what that is. I think you certainly experienced that.
Yeah. Yeah, I have a lot of people come into my door that are like, so why am I here? So I have a question for you two. What do you know about the pelvic floor?
I think this is for you, AJ.
Yeah, that's true. Adam knows a
lot. So basically, what I know about the pelvic floor is that there are some muscles, some small muscles that are really hard to say, that basically encapsulate the bottom of the pelvis. I think encapsulate's probably the wrong word, but you know what I mean. And I actually look at it as a part of the core, where if we think of the core as a cylinder, and we use this generic example of the cylinder core, where the top of the cylinder is the diaphragm, actually. And so that's the other part a lot of people don't know. We have the diaphragm above, and we have the pelvic floor below, and they kind of work a little bit in synchrony, I feel like. And then around that, what kind of circumferentially covers the core is like a bunch of muscles, but we have transversus abdominis is the big popular one in the rehab world, but we also have pretty much everything else. Rectus abdominis in the front, that everybody likes to get that stacked 6-pack or 8 whatever pack. Then we have, the obliques, and in the back with the erector spinae and stuff like that. So yeah, that's the pelvic floor would just be those muscles on the bottom that really attach to like the sacrum and the coccyx and the pelvis bones.
Yeah, no, that was really good. I'm impressed. So that is very true. It's an underlooked part of the core. And so our pelvic floor, a lot of times people are like, why am I having physical therapy for this? And it's because our vaginal opening, rectal opening, or like cavity, that's muscle. And so what are physical therapists trained to treat but muscle, connective tissue, all that sorts of things. So that's kind of the first thing I tell patients when they come in the door, like, nope, you are in the right realm. Like, we are here to help you. It's muscle, it's things we can work. It kind of works like the rest of our body, and it's an integral part of our core that gets overlooked a lot. And so kind of what you said doesn't encapsulate. It's more like a bowl at the bottom of our pelvis is how I describe it. But you're right, like the bottom of the soda can. And there's lots, you're right, there are lots of muscles. We'll collectively call them the levator ani, because that's what they do, is they lift or elevate, as well as we have some of our deep hip muscles kind of can be considered a little bit of the pelvic floor as well. Most typically the obturator internus is looked at a lot because it lies like right next to our pelvic floor.
And so that's basically like a hip rotator, right?
Yes, yeah, a deep hip external rotator. Mm-hmm. And so we see a lot of relationship between the hip, the pelvic floor, the core, the pelvic floor. And then exactly like you said, our diaphragm and our pelvic floor actually work pretty much in synchrony with each other. They have what's called a phase-locked relationship, where as that diaphragm drops when we take a deep breath in, our pelvic floor actually lengthens. And as we exhale, our diaphragm lifts, our pelvic floor lifts as well. So that's where I spend so much time talking about breathing with my patients, which I know is also kind of a big thing right now in the physical therapy world in general, or I guess kind of a fad. But for pelvic floor, it really has like a pretty direct relationship. So we work through breath a lot to help people connect to their pelvic floor, because it's not a group of muscles we really think about using a whole lot. So sometimes it takes some pretty good brain body awareness, a lot of practice before we can actually get those things working. But it tends to have a couple of functions. So it has a sphincteric function, which means it's supposed to, not let us go to the bathroom when we don't need to go to the bathroom, and relax and allow us to go to the bathroom when we are. But it also has a really large part of our support system. So it is part of our core. Research has started to show, well, actually the research is older, but our pelvic floor is what we call an anticipatory part of our core. which means before we even move, before we take a step, our pelvic floor is already like preparing for that movement. So when we see issues with the pelvic floor, we can actually see some of those like hip issues, core issues. I've even, Julie Wiebe is someone, she's a really well-known women's sports therapist. And she even talks about like, we might see shoulder issues that are related to kind of dysfunction of the pelvic floor. And so it's has more of a relationship than we think with our whole system.
Yeah, absolutely. I've had some people with kind of almost ambiguous hip pain that we can't quite figure out. And then through some questions, or a lot of times it's something they just happen to say on that day I see them that kind of clues me in that there's something else going on here. It's not a true hip issue. And so then I start questioning kind of down more of that rabbit hole. Is it pressure, heaviness, any leakage issues, that leads us to think that there might be more of a pelvic floor relationship here that needs to be evaluated a little bit further.
You're welcome. I taught him that.
Yeah. But I think but you're right that people come in for physical therapy related to their pelvic floor for whatever reason, and they don't know what's going on. What are some things that, might clue to them that this is something they need to seek out? Because it's not really as clear as like, oh, you rolled your ankle on a run and need to go get that checked out, or I'm having some knee pain, or something that's very obvious.
Yeah. So a common phrase in the pelvic therapy world is common but not normal. And really we're trying to change that to more like common but not optimal, because we don't want someone to feel like abnormal. But common but not optimal means that like a lot of issues that I treat people for, so like leaking, it's become kind of normalized in our society. They're like, oh, you've had kids, like you're maybe a little bit older, like you're just gonna leak, that's gonna happen, like congratulations, you had kids. And it's like, that's not the case. It's a group of muscles that we can work, we can make improvements. And so trying to kind of break that stigma is a large part of what I do, because I'll have women that come in for other things, maybe pelvic pain, pain with intercourse, pain with tampon usage, pain with an OB exam, that will mention the leaking as this like side of like, oh yeah, well, I've had 4 kids, so I leak and I might wear a pad that I change once a day or something. And it's like, stop, nope, let's like rewind, go back. Like that's not normal, or that's not optimal. Like we can improve that too. So even though they might be coming to me because of their pain, a lot of times they don't realize like, hey, leaking is something that we can correct. Like it's something that we can improve. So I treat a lot of leakage issues, both bowel and bladder. Constipation, actually, physical therapy can be helpful with like constipation. Pelvic floor, like pelvic pain, that kind of ambiguous hip or back pain. A lot of times I'll get referrals that therapists have tried everything else. So they're like, let's check pelvic floor. Pain with like menstrual cycles. I see conditions like interstitial cystitis or endometriosis, that sort of thing, as well as I'll see a lot of like during pregnancy and postpartum, just kind of working to regain normal, or in pregnancy to kind of reduce symptoms as much as possible. And then I'll see a lot of like diastasis recti, which is that separation of the abdominals, typically after pregnancy, but can happen at other points too.
Nice. So you mentioned like someone comes in for pain related to the pelvic floor, and then you're interviewing them, talking, just about the history, and they mention this leakage, and that being this other thing we can treat. Are those correlated at all?
Oh yeah, a lot of times they are.
So you clean up one and then the other.
Yeah, I mean, not necessarily like, it's kind of like back and hip pain. Sometimes it's related, sometimes it's not. Same sort of thing. Like a lot of times if we clear up one, we're definitely making improvements in the other, if not clearing up the other. And one thing I forgot to mention, I also treat is like prolapse. So pressure, heaviness, feelings of fullness in like the pelvic region, all common complaints. So those are things I encourage orthopedic PTs to screen for, although it can sometimes be an uncomfortable conversation. Adam has gotten more comfortable with it as I've emphasize to him how important it is. You actually have it in your intake now, right? For new patients, like just questions about leaking and that sort of thing.
Yeah, I send it to all my female patients. They all get it.
But it's important to be asking those questions, because a lot of times they just don't even realize like it is something that can be improved. They think they just have to live the rest of their life with it. I can't tell you how many women I treat that are just like, oh, well, I just wear like really dark colored pants when I run, so I don't have to worry about it. Or like I am, having to wear a tampon or a pad when I'm running to like kind of prevent some of these issues. And it's like, nope, let's like try and make sure that you don't have to do that, because end goal is to not be leaking when we're running, when we're lifting, when we're picking up our baby, anything like that.
Yeah. AJ, anything to add on at this point?
No, it's all, I think I was going to ask something related to what you already asked, but I was basically, when you were talking about leakage, now somebody might just be like, oh, well, I leak. And you might be like, well, this could actually, you address that, and maybe it also addresses that's partially addressing what we're already trying to work towards, right? That's going to be a symptom of the root cause or whatever, right? And so another symptom is kind of what you're seeing me for. So
exactly. And so that's why when you're like seeing someone with kind of this weird hip pain, back pain that's maybe not resolving with normal treatment, asking those questions, because that'll clue you in like, oh, maybe pelvic floor is involved. So we used to think, kind of drives me nuts. I have a little bit of a soapbox. A lot of times doctors, especially OBs, and not all OBs, but they're just like, oh, just do your Kegels and it'll be fine. But our pelvic floor, having an issue with a pelvic floor, it's not always a weak pelvic floor. It can be, but it can also be a pelvic floor that's not moving through a full excursion. So in the pelvic floor world, they used to use the word hypertonic a lot, and we're kind of moving away from that, just like we're starting to move away from like trigger points and that sort of thing, because it's not necessarily like a true spasm or anything like that. It can be. I have seen that before in pelvic floor patients, but a lot of times it's kind of that like central sensitization, or that like sympathetic response of nerves are sensitive, and so our muscles are kind of responding by holding a lot of tension and aren't able to move through a full excursion. So that's kind of what, again, that's something I have taken from some of the Julie Weeby courses I've taken. She really calls it like an excursion. So we need our pelvic floor to be able to lift, but then it also needs to be able to eccentrically lower and relax and lengthen. And so while Kegels can be a part of what we're doing, we really need to make sure that we're addressing what's actually going on with the muscle. So if it's truly just a weakness issue, I have had patients that cannot contract their pelvic floor. It's not tight, it's nothing. They just have no brain body awareness with that muscle and cannot contract it. Yeah, then we might want to work on addressing that. But I'd say much more of the time, especially after pregnancy, I see a lot of that muscle holding a lot of tension and just not being able to eccentrically relax or lengthen. And so we'll do more like reverse Kegels, where we're trying to emphasize that like excursion, that movement, because with patients a lot, will describe it as like, if I have a tight bicep, right? My bicep isn't able to move through a full range of motion. My arm's not super functional. Like if I drop something and I try and catch it, probably not gonna be able to catch it very well. Same thing happens with our pelvic floor. If it's not available to move through that full excursion, when we're running, when we laugh, when we jump, when we cough, it needs to have that full response. And if it's not able to, then we have those issues with like leaking or pain or that sort of thing.
So I kind of use the terminology I use with my patients sometimes is, I don't like to necessarily call something weak or dysfunctional. I'll say that it maybe needs improvements in muscle performance.
Yeah.
So I guess maybe something like that, right? Where maybe it is strong, but it's not performing in the way that we want it to, or in synchrony with, or synergy, whatever word you want to use with the movement or activity that we're doing. And so just to clarify, Kegels are for strengthening kind of pelvic floor, I guess.
Typically, your true Kegel would be a maximum contraction of the pelvic floor.
Okay.
And so I hardly ever give a true Kegel A lot of times we'll do maybe some what we call like quick flicks. So our pelvic floor is composed of both type 1 and type 2 muscle fibers, primarily type 1, but it does have some type 2, especially for those like quick responses. So we'll do some like quick flicks where we're working on that like power a little bit more and making sure it can relax, as well as we will do some endurance holds. But then, yeah, we'll do what I call like reverse Kegels, where we're trying to do that lengthening. Or we might do like a stepwise contraction where we're like contracting 50% and then relaxing. It's sometimes I do give a max voluntary contraction, but not super often unless it's a true just weakness issue.
We know that all the listeners are doing Kegels right now. But no, all 6 listeners.
So I have a question then. So when it comes to pelvic floor musculature, is it more about bringing awareness and control rather than a true strengthening that we, like AJ and I tend to have an approach where we just load it up kind of in a very simplified manner. Like you could just describe it as, let's just load it and get as strong as we possibly can.
Yeah.
As opposed to, it sounds like here it's more awareness driven, being able to control it.
Yeah. I would say that's, at least in the beginning, a lot of the emphasis in the beginning. Sorry, now I have the hiccups. As we continue through therapy, I will kind of load it a lot more. So I'll have them do like a squat, and we might add some Kegels in with the squat, or a clam or a hip abduction or something, like trying to load that area. But initially I found a lot. So sometimes my first session with a patient is just a lot of education. I might give them like some breathing, maybe some like try and do some pelvic floor just awareness exercises. And so often by that second or third session, 1 week, 2 weeks later, they're like, it's not ginormous improvements, but they're like, oh, I have noticed XYZ. Like I have noticed a change just by implementing these few small things that we talked about just through education, because it's a part of our body that we don't really bring awareness to until there's an issue, right? Like, do you ever think about your pelvic floor?
Is that a serious question?
Yes.
Okay, I gotta say no.
Right, because yours most likely, I'm assuming your pelvic floor is functioning optimally. So like, why would we worry about it? We don't think about breathing until we have like an issue with COPD or something that's causing problems with breathing. And so it takes some time to find that relationship with our pelvic floor. And research is kind of unclear on the true total, but I've heard anywhere from about 50 to 70% of women do a Kegel wrong, because no one ever actually tells you. They're just like, do your Kegels. But what is a Kegel? Like, doctors don't have time to just sit there and explain that. By the time they see me, they're already having problems, and they probably were told to do Kegels and don't actually know what they're supposed to be doing. So
Gotcha. So it's like telling somebody they need to do bicep curls, but they've never seen somebody do a bicep curl in the squat rack, so they don't know what to do. Kind of deal.
Yeah.
Cool. So we kind of touched on this before, but let's switch gears a little bit here. So in terms of, with my history of kind of being more in the track cross country realm, seems to be a common thing that girls and women all discuss, is that you've never really fully exerted yourself until you've peed yourself at the end of a race. And so we've talked about how, that's peeing or leaking with exertion is not necessarily something we want to have, because there's a more optimal way of doing things. But when you're at that complete kind of red line, totally exhausted, is that a situation where it's okay, or is that still something we would want to address?
Yeah. So funny story about that. There's actually like a tweet of mine from several years ago out in the universe that was like in Canadian Running magazine or something. Like one of the authors like used my tweet because Emily Infeld, who's a professional track athlete, had tweeted about like peeing at the end of a race. I don't remember quite what her tweet was about, but I responded to her tweet and I was like, hey, well, I think it's great that you're bringing awareness that these things happen. Like she kind of normalized it in her tweet a little bit, kind of along those lines of like, oh, I was like just totally exhausted myself. And it's like, it's not necessarily something we should be normalizing. So somewhere like 5 years ago, there's like an article out there in some random offshoot magazine that has my tweet in it. And the author actually had like messaged back and forth with me a little bit. And I would say the answer to that is it depends. You know, that famous physical therapy answer in PT school all the time. If you have truly exhausted yourself, you might pee yourself. I mean, it's kind of one of those things where when you cross the finish line and your whole body just like relaxes, guess what also is probably going to relax? Your pelvic floor. And so if you do have if you might already have some baseline issues that aren't an issue, but then now it's coming out, yeah, it could potentially happen. But I try not to normalize that too much because we really shouldn't be peeing our pants. Like we should be able to be continent and in control. So I'd say it's one thing, like if you literally are collapsing across the line, like gave every ounce that you had, like your whole body is just like, whew. But just finishing a race, no, you really, in my opinion, shouldn't be.
Good. You ever heard of that in the ultra world?
No.
Well, that's probably in the ultra world. If someone has to pee, they just hop into the bushes and pee.
That's true. Yeah.
Or pee themselves. I've heard of that too. Like purposely pee themselves.
Maybe who knows? I mean, I don't think people are openly talking about it if it does happen, but yeah, in the ultra world, I gotta imagine that, especially some of these longer ultras where people are truly exhausting themselves, but typically these longer ultras, people are a little bit more spread out so they can more conveniently just pee whenever they want to.
Mm-hmm.
So maybe their bladder is not quite as stressed there. I don't know.
Yeah. I did read a book about a triathlete. Oh, what's her name? It's out there. Chrissy Wellington, who was like a really well-known triathlete, did some Ironman stuff. And she talked about during her races, like, and I don't recommend this, but she would if she had to go to the bathroom, she would just pee while she was on her bike, but she would like hold it until one of her competitors was next to her. And then she would just pee as a way to like make them back off and not draft off of her. And I was like, I mean, I guess that's one way to use your bladder. Like, you've got to have pretty good control to do that. But I don't know that I would actively recommend just like peeing on your competitors.
That's impressive.
Like Making Strides podcast does not endorse this.
Yes. Like being able to pee while you're working that hard. I mean, so during my 100-miler last month, my knee pain got so bad that I had to resort to walking while peeing because my knee would lock up. Like I swear to God, I'd stop to pee and my knee would lock up and it was so bad. So it was like so freaking painful. So I was like, I'm just going to walk and pee at the same, which is very difficult for me. It was very difficult. And I did find myself.
So if you think about it, so that's one thing that I actually tell patients, like who are maybe having difficulty emptying their bladder or that sort of thing, is we call it a restroom for a reason. Like we're supposed to relax when we're going to the bathroom. I recommend not even really hovering over a toilet seat, because when we're doing that, our muscles are still on some level trying to kind of stabilize us and trying to do some of that postural support versus truly relaxing. So yeah, like walking and trying to pee, not going to be the most optimal.
I was definitely not emptying completely, for sure. Yeah. Like I found myself urinating fairly frequently while doing that.
Yeah.
God, what a wild experience.
Yeah.
Walking and peeing.
No, seriously. And then what the funny part is, you guys saw the video of my 100-miler, but my buddy who was pacing me, recording most of the video, he sends me all the raw footage and I'm looking through it and there are several videos of me pee walking. There's several videos of me pee walking. I'm like, Rob, what is this? And I send him the final edit of the video after I edited everything. And his only response is not enough peeing. So anyway,
that's pretty good. Amelia Boone actually had a tweet after Run Rabbit about like women and peeing, and like there's this whole conversation like in her threads or whatever it's called on Twitter. I think that's a thread, about like women complaining about like, because women, you have to kind of like pull your pants down, you kind of have to squat to pee. And 80 miles into a 100-miler, squatting's not so easy anymore. No. And so that's a really interesting thread. If anyone wants to hear more about the ultra
world
running,
peeing
ultra world peeing
experiences.
stories. Go check out Amelia Boone's thread about it.
So let's touch on something a little different that people might not recognize when it comes to being evaluated by a pelvic health physical therapist, and that's the internal exam. What is that? When might you do that? Just so people are aware. I don't know. Do people come in and are like, wait, what is this?
Yeah.
Like not just pelvic health in general, but the actual exam piece.
Yeah, definitely. I mean, a lot of people come into my door and they have their doctor just told them, here, go to pelvic floor physical therapy, or they read about it online. So they show up and they have no idea what to expect. And so while internal exams are a component of pelvic floor therapy, I always tell people it is never something that they have to do. There are lots of things that we can work on that don't involve that internal exam. And it is always with patient consent. Like I do have them give me verbal consent as well as sign a consent form. I give them the option of bringing someone into the room because unfortunately in the pelvic floor world, I would say there's a high incidence of patients that have some form of trauma in their past, whether that is sexual abuse, emotional abuse. Sometimes it's just their delivery was really traumatic. And so I never want someone to feel uncomfortable with what we're doing. They need to feel like supported and they have to be okay with whatever we do. So I always explain the internal exam, but I make sure they know upfront, like it is, if they never want to do it, we never have to do it. But I explained that it does give us quite a bit of information that we can't get from an external exam. And so typically what an internal exam is, it's similar but different to an OB exam. So there's no speculum, no stirrups, which are sometimes, well, you guys have never been through a pap smear, but that's sometimes the most like scary thing is they make you lay on your back and you put your feet up in these literal stirrups. And then they have this like speculum, like this like clip thing that they like open your vaginal cavity with so that they can see what's going on up there and take a swab and stuff. Super not fun. And so a lot of times when I tell people we don't have to do any of that, they're like, whoa, okay, like this doesn't sound so bad. But it is a similar position. I'll usually have people kind of semi-reclined or laying on their back. And it's just like a 1-finger insertion. We use a little bit of lubricant so that it's a little more comfortable. And it's just kind of actually getting on those muscles and seeing what's happening. Can I feel a contraction? Can I feel that relaxation? Do we have any like tenderness in those muscles? I can kind of strum the nerve that runs through the pelvic floor, the pudendal nerve, see if that generates any sort of symptoms. Versus with an external exam, and which you guys can totally do an external exam. It's not that hard. But it's usually side lying, kind of feeling underneath the ischial tuberosity. There's kind of a fossa that you sink into a little bit where you can start to feel externally pelvic floor. And you can have them try and squeeze and relax, but a lot of times you're kind of pushing through other hip muscles, right? So it can be harder to tell for sure what's going on. Are
you trying it out right now?
That's not so bad. I've shown you how to do it.
Yeah, I don't quite get it. I'll just refer.
Yeah,
It's
and I mean,
fine.
it's like it's a very finite movement that you're looking for.
I can feel it.
Yeah. And so you just want to make sure you're not getting a lot of like gluteal compensations or breath holding or like abdominal compensations that are creating some of that. So I tell people like, we have this external exam. We don't have to do this internal exam ever if you don't want to. A lot of times after a couple sessions, people that were initially hesitant will decide like, you know what, I think especially as they kind of get to know me and we develop like a relationship, they're like, no, I feel comfortable enough to do this. But I've also had patients that have never wanted to do one and we have resolved issues without ever having to do one. So if I always tell people, if that's like what's holding you back from going to a pelvic floor therapist, don't let it, because there's so many other things that we can work on. A lot of times, even just doing like hip work helps the pelvic floor because they do work together pretty well and we see like overflow into those pelvic floor muscles. So for example, I've treated, an 80-year-old woman who had dementia. Obviously, I'm not going to do an internal exam on someone like that because they can't give me consent. And so I didn't even really try and do an external exam because she can't understand what I'm asking. But by doing some good hip strengthening, doing some breathing, like her husband gave me a self-report, 6 weeks down the line, and we were really treating more hip stuff anyway. He had just kind of mentioned the incontinence in the eval, like as something she struggled with. And at one of our progress visits, he was like, oh, by the way, like I've noticed her incontinence has really improved. And we didn't do anything with the pelvic floor. So you can get results without even doing things directly to the pelvic floor. So
Absolutely. Cool.
Nice. Are there any issues or conditions where like you'd really prefer to have that internal exam?
Yeah, I would say it's never a necessity. I want to put that out there. Like it's never a necessity. It can be really helpful, for example, with someone who is having pelvic pain, just because we can really get on those muscles. A lot of times it's a sensitivity issue of those muscles, like they've just become sensitized to pressure, to movement, whatever. And so actually getting on those muscles, I'll do like internal manual treatment to retrain those muscles to kind of normalize that pain sensitivity threshold. So a lot of times that can be helpful, but there's also things I can teach them to do at home that they can do themselves without me being involved that can help with that. So
Nice.
Yeah.
How about we talk about something we can all chime in about?
Down for whatever.
Yeah. So it's common for females to have this perception that when they start missing their period, that means they're fit and that they're ready to race and whatever else they think, aligns with that. Emily, do you want to start us off about that?
Yeah. So I guess first thing is periods are normal. It is a sign of your health as a female or that you are having your period. And so normal can be different for different people. Typically anywhere from about 28 to 35 days of a cycle is considered normal. But even each of your ovaries can ovulate on a little bit of a different cycle. They don't, it's kind of like one ovary might ovulate every 28 days, and then the other ovary might be more like 34 days. And so it is important to kind of track your cycle over time just to kind of find that like what your normal is. For example, I've always been someone who was on like the farther end, like 34, 35 days for my cycle. And for the longest time, especially like when I was in high school, I was like, what is wrong with me? Like, why am I not having a period? And it was just on that later end. So that can be normal. And it can be normal, again, like I said, because ovaries can ovulate or release the egg at different times. Like it can be maybe 28 days and then 32 days. So just tracking that. But missing your period is one of the first signs that you're probably in relative energy deficiency syndrome if you're a female. Men can have this as well. It basically means that you're just not consuming as many calories as you're expending for whatever reason. It used to be called female athlete triad because it generally affects women a little bit more. And it used to really strongly be like a lot of times they assumed that if you had this, you also had an eating disorder. And we're starting to kind of separate that out and realize not every person that has relative energy deficiency syndrome or a missing period has an eating disorder or disordered eating. They may, but a lot of times they're just not realizing how much they need to be consuming to make up for what they're spending when they're exercising.
Yeah, absolutely. So we mentioned my intake for females earlier. One of the questions is, have you missed 3 consecutive periods? And that just starts to give us a reflection of, do we have some sort of nutritional component to this? And what is the, if we extrapolate that a little bit further, are we now looking at a potential kind of bone stress injury kind of risk? and have compromised bone health because our hormones are a little off, because we're not consuming enough calories. And it becomes, I don't remember the numbers exactly, but it takes a long time to resume normal function of those. And then if we do have compromised bone health, I mean, you're looking at 6 months to a year for that to normalize. So this is
It
like
can take up to a year for your period to normalize.
up to a year for your period to normalize. Thank you,
Not
Emily.
not always, but it can't, like, up to.
It can.
Yeah.
Sure. So I mean, this is, you have a short window of error, but the consequences of that are very long term and just does not set you up for health.
So occasionally a woman will come in with some potential stress fracture symptoms. And so I'll run them through the questions of all the questions that you probably know right off the top of your head, Adam, but, and even Emily. But so one of those questions being, do you track your cycle? Have you been, having regular periods? And probably 50% of the time women are saying that, they don't have a period because of birth control or something like that. Right. So, or they're having their period, but they can't track it type thing. Right. So, I mean, what are your thoughts on that type of situation and being able to lose that kind of beacon of health in that situation?
Yeah, so that's one of the times it becomes really important to look at those other aspects of, like, do they have some sort of relationship with eating that might be impacting what they're doing. Like, unfortunately, birth control is so, especially with the pill, a lot of times people will say, like, yeah, I have a regular cycle, I'm on the pill, not realizing that that breakthrough bleeding we get with the week of a sugar pill is not the same thing as having a cycle. It is not a true period. And so, unfortunately, in those athletes, it can be hard to kind of differentiate. And so that's why you really have to kind of look at those other aspects of, like, their relationship with eating, their, like, exercise activity levels, that sort of thing.
Mm-hmm.
Yeah, and there's a multitude of reasons to be on birth control, but one of the reasons that some physicians will put people on them is for bone health. I guess there's some evidence at some point in time that it was good for that, which is one of the reasons I have that question on my intake and ask people is, what is the reason you're on birth control if you're open to sharing that? Because if it is related to bone health, then that starts us thinking, a certain direction of what might be going on with that individual.
Mm-hmm. Interesting. Cool.
Yeah. Anything to add?
No, I mean, that's pretty much my experience there. And, I was just curious, how that kind of affect, but obviously, that's just one question too. You're right. There's a whole battery of questions. I'm trying to see if somebody's in this kind of red S state or relative energy deficiency in sport kind of state. And just, it's rarely the case where it's like, yeah, I actually haven't been getting my period. And then what do you know? They have a stress fracture. It's never that easy. It's never that textbook. So it's always this compilation of, like, where they'll say something like, because my next question, you're right, would be like, do you have a good relationship with food or whatever? And then maybe they're like, oh, I do now, but I used to have an issue. What sports did you play in your adolescence or whatever, prepubescent years and stuff like that? And it's like swimming and stuff like that. So you just piece things together in other ways. So, but I was always just curious. Do you think that I guess this is a good runoff question then, off of that, for women who are a little bit more serious about their endurance athletics, do you think it's to their advantage to maybe consider weighing the pros and cons of the type of birth control that they're on and whether or not they should potentially switch or come off of it in order to kind of have the benefits of that?
Yeah, that's actually something that I'm really interested in and would like to learn more about. I don't know that there's been a ton of research done in, like, serious athletes about, like, research on periods or pretty much anything pelvic health, women's health related is eons behind anything related to male health. Sorry.
Yeah, totally. No, I totally agree. And it's a
And
shame.
so, yeah, and I think that's a really great question. And I do believe that there is currently some research going. I remember seeing a call out for like maybe a year ago on like Twitter or something, asking for like, hey, if you're a Division I NCAA athlete, like we want to ask you questions about like your period and birth control and that sort of thing. So I do think it's something that's being researched more. I can't say that I know enough about it to like give someone like, yeah, you should do X versus Y versus Z. There's some pros and cons to all of it. But I do think that, especially in someone who has a history of bone stress injuries, it's probably important to be paying attention, maybe trying something that's a little bit more natural of an option to see if we can restart that period and what that looks like, because it is a really good indicator of our overall energy health, energy system health.
Because I guess, you know, the obvious benefit would be being able to track your period, but then there's also a lot of unknowns with these exogenous hormones and stuff like that. And we, I guess, just don't know the full effect of, you know, the effect on performance and health in general. So you're totally right. Like there's a definitive, obvious reason why this woman chose to go this route. And so then, you know, if we were in a world where we had some really good information and research on what that really means for their health and performance, then they can make a really educated decision on if that's something that's worth it for them. But we're just, I guess, not there yet.
Yeah. So I am interested. I haven't read, I feel like I'm the one person in the world who hasn't read Stacey Sims' Roar yet. I am interested in kind of reading her thoughts on things.
Yeah, I was just thinking of her in this conversation, and I do think I remember her posting at least once, maybe if not several times, about kind of trying to get women off of different forms of birth control for performance and health reasons. So I'm curious as well. You know, it's a book I should read as well. And I do want to. I just have so many.
Yeah, and I know that is like her stance, is really trying to go the more natural route. And I would say for me personally, like that is something I would advocate as well, just because if, you know, obviously, again, women are on it for different reasons. If you're on it for like a birth control true reason, like let's look at maybe some other options. If you're on it for like acne, a lot of women, you know, in high school might get put on it for acne. Let's maybe look at some other options, you know, versus sometimes it's other hormonal things that are going on. You know, I don't know enough about that to say like, let's stop that. Like hormones aren't something to mess with. But yeah, I agree. I really think that it gives you, I've learned a lot about my body and my health since stopping birth control. I was put on birth control in high school to try for like the purpose of acne. And looking back, I'm like, really, there's not like something else we could have done? Because my end of like, and through high school and then a little bit into college, I did have a little bit of issues with like some bone stress stuff. And I was having some like delayed periods in high school. I know one time I think I went like 50 days, which is pretty long. But ever since I stopped birth control, I want to say like my sophomore, junior year of college, something like that, like, and been tracking my cycle, like I've had a really good understanding of like, hey, I'm training really well. Like my cycle is very regular. Or if it's like maybe delayed a couple days, I've never had a huge delay again, but maybe like I was supposed to have my period and then I ran like Leadville. And so a couple days late, it's like, yeah, I really taxed my energy systems, like that sort of thing. So I do kind of encourage, if people are open to it, trying to go the more natural route.
Oh man, I just feel like there needs to be so much research done. Just you saying that and me thinking about all these ultras that in women running ultras and what that does to their periods and their cycles and just like, even just like, these don't have to be complicated studies. These are just surveys. These are just like asking women what happens to them after races, you know? God, I mean, yeah. So that's,
especially those running like 3-4 ultras in a season, like just a lot of unknown.
Absolutely crazy. Were there any other major points that we wanted to kind of hit?
It's nothing I had thought of.
I mean, I could talk about the pelvic floor for a long time, so you would have to stop me. I think my biggest takeaways for people are really like, for clinicians, especially just the general like orthopedic clinician, like really ask those questions. Like ask if they're having, heaviness, pressure, leaking, pain, all of those things. It's just a piece that gets overlooked so often that if we addressed it, like it would help so much down the line. I wouldn't have to see that woman when she's 80 and changing her pad 5 times a day. If we can treat it when she's 30 and maybe leaking a little bit with running or with jumping or CrossFit or whatever. And don't feel like by that person seeing a pelvic floor therapist that they're going to like steal your patient either. Like there can be a really good relationship between the two. But it is important to kind of get that piece and make sure that piece is being addressed.
Absolutely. I tell people too, I'm like, if a general orthopedic PT is having trouble with a runner, I hope that they would refer them to me. And
Right.
out of respect for that, when something is outside of my scope and I feel like there's a better specialist out there, I feel obligated to refer. So I hope others feel the same. But, yeah,
I agree. I just recently, unfortunately, had a patient who had to ask her doctor twice after her 6-week checkup to get pelvic floor PT because she wanted to get back to running and she wanted to get back to other things, was having symptoms. And her OB sent her to a therapist who told the patient, yeah, I've taken like a course, but I really don't like to treat it. Like I don't treat it that often and it's not my specialty. And they did a few things. And it's like, why are you referring to someone who, this person specifically wanted this? And so luckily she found me and has been working with me, but she was frustrated too. Like that makes it all the more frustrated. Like if it's something that you don't want to be treating, like please refer on. Please.
absolutely. So I guess my take in a lot of this is if somebody has issues, they shouldn't necessarily try to normalize those things or try to justify why they have those things. They should really go and see somebody. And just in case, and just to get checked out and just to make sure it's not like a major issue. But another thing is that it's not like, just like every single thing that we read on the internet, we shouldn't feel like we can treat ourselves. And a lot of times in the pelvic world, that ends up being Kegels.
Mm-hmm.
And now we could have a multitude of issues, one of which is the Kegels need strengthening, in which case maybe Kegels do their job. But there could be some other muscle performance issue or a relaxation issue, or you had mentioned some sensitization issues. And just for the non-clinician listeners, basically just like a nervous system component that is complex and complicated that has to do with the patient's pain experience that may not specifically be the fault of any specific tissue, right? So there could be a lot of things going on, and it is definitely not the layman's person's responsibility or ability at all to be able to discern between those. And they could get drastic help from a pelvic health PT.
Yeah, I think that's a great way of wording all of that.
Cool. Okay. What do you got, Adam? Anything to end with?
No, that was perfect. I don't even want to try and follow up.
Okay. So Emily, tell us where you're working currently. If maybe somebody is kind of liking what you're saying or kind of feels like maybe they want to work with you and they're on the Front Range, where can they find you?
Yeah, so I work at Ascend Physical Therapy in Colorado Springs, Colorado. And so we take most insurances. So we also have self-pay options. So feel free to come see me.
Cool. Okay. Adam, you got one last.
If somebody wanted to reach out with a question, is there a preferred method of doing so?
Oh, I guess probably email.
Okay.
We'll have
put an email in the show notes.
We'll have email in the show notes. We'll have kind of the clinic you're located at and your Instagram if you want it, or no, is that private?
Sure, that's fine. I mean, I don't post a ton of, there's like the pelvic floor tidbits in there, but it's a lot of running.
Cool. Okay. And then of course,
People
Adam,
might like that too.
yeah. And then of course, Adam and my Instagram and website information will be in there as well, in case anybody wants to reach out about anything, or even if you just want to use us as a way to get to Emily, if that's easier or whatever. That's pretty much it. Thanks for listening, and hope everybody has a great rest of their day.
Make some strides.
Go make some strides. Emily's got to say it.
Make some strides.
Make some
That
strides.
doesn't make much sense.
Make some strides in life, in running, in
Okay,
everything.
make strides. Got it.
Yeah,
I thought I was imagining like
We're trying to make strides in the industry of physical therapy,
Okay,
in
yeah,
educating
get it
patients and runners
Yeah.
just like strides. Strides are so much fun. Who doesn't like strides?
I was
Anyway.
imagining just like making strides, like I don't know.
Okay, we're gonna end this. See you guys.